Hello, good morning everyone. Thank you, Emma, for the kind introduction. So I'll essentially launch straight into it. So as Emma mentioned, I'm going to talk about the care of emergency laparotomy patients. Particularly going to look at some of the work that's gone on over the last few years to really define what best practice is for these patients. And to think about how we as individuals, as hospitals and as a region can look to improve the care we provide. So, first of all, why is this important? First of all, laparotomies are common. In the UK, we do up to 30,000 laparotomies a year. In the East Midlands, that number for all of us here probably is about 2,500 that we contribute to the national numbers. We know the high risk of complications. We could say that from, we could all tell me that. It's useful to look at the numbers. And we know that the mortality, 30-day mortality from emergency laparotomy is about 10%. 3-year mortality is more than 30%, which is huge numbers when you compare that to elective work, for example, that we do. There's also long-term morbidity, and we don't really know exactly what that is in terms of numbers. It's not working again. Oh. But what we do know is that by providing good, high-quality perioperative care, we can stop that, the emergency laparotomy, ending with short, long-term complications and help to prevent that long-term morbidity. So, what is this high-quality care or best practice that we're aiming for? Now again, I could open that out and I'd probably get these same answers. So, best practice care, a defined pathway of care for these patients. So that doesn't mean you do the same thing for every patient, but it means that for each individual patient, you know what's going to happen, when it's going to happen, who's going to do it. And in terms of what you're going to do, they're all high-quality interventions, so evidence-based, done in a high-quality, competent manner, essentially. Timely care is important. Not having unnecessary delays in any of those pathways. I'm going to use the word pathway a lot in this talk, but the truth is that a few years ago, 5-6 years ago, most hospitals didn't know exactly what their own pathway of care looked like, let alone what the best practice pathway of care would look like. Until these guys came along. So the colleges, HSRC, HQIP, started the NELA project. Okay. And NELA has really been instrumental over the last few years in defining what best practice is for emergency laparotomy patients, and also helping us as hospitals and regions improve in what we do. I'm sure we've all seen it before, but NELA is a massive audit with extensive data set. So for each patient who has a general surgical emergency laparotomy, we collect over 100 data points, including demographics, process measures, outcomes. Now if we stop and think about that, so you've got 100 bits of data, 30,000 patients a year, and that's been going for 6 years now. So the evidence base from NELA is absolutely huge. So you can really rely on what they say, is what I'm getting at. From the data set, they've chosen, or essentially, some key process measures have been chosen. 3 of those look at the pathway of care, 3 at the quality of care, and 4 at outcomes. And I thought it was important to talk about those, particularly in a talk titled Best Practice in Emergency Laparotomy, because these are things that we really should be striving to do. So the pathway measures. Important thing, risk assessment. We need to risk assess all these patients as early as possible in the pathway. And this has been a key focus of all the NELA projects. To the extent they've even made their own app and their own website calculator to allow us all to score this easily. Reason it's so important is that a risk assessment really defines or sets the tone for that patient's pathway of care. High-risk patients getting expedited care, consultant involvement, and all the things that go with that. Next thing, rapid access to imaging. This was chosen because essentially it's a historical stumbling block to getting quick care for lots of patients, trauma patients, for example, laparotomy patients. They'd often wait a long time for a CT scan and a report. And this has been a big focus of NELA and within all our regions to try and get time-critical scans for these patients. So, you know, your trauma patients get within half an hour, we get them within 6 hours, ideally. The next key pathway measure is arrival to theatre within the appropriate times. This is essentially a surrogate measure for how well our pre-op pathway is working and how good our theatre access is. Quality measures, always a contentious one. But NELA say a key process measure is to have consultant presence in theatre for patients who have got a NELA risk score of more than 5% mortality. That's surgeon and anaesthetist. Like I say, often contentious, but if you think about some of the elective work that we do, an elective case with a risk of 5–10% would normally have a consultant there. And for those patients, direct critical care admission. And a slightly newer one, which sort of emerged since the beginning of the NELA audit, is post-operative care of the elderly review. Used to be for over 70 years, is now for over 65-year-olds. And these are things that we should be striving for to try and get a quality pathway. And in terms of outcomes, just for completeness, the ones that are most commonly reported are unplanned repeat operation, unplanned critical care, and length of stay in hospital. Mortality is sort of, we get it a year later, because they give us a 1 year mortality. So we pour this data into NELA, and they give us a lot back, essentially. So NELA is one of the first audits that let us, as hospitals, access our individual data for what we're doing, which helps to drive quality improvement. There's quarterly reports, which again help to drive local improvements of whatever we're going to do. There's also an annual report. Now, those lovely people are from the report published last year, which looks at 2017 data. So the new report was published this morning at 8 o'clock, which is convenient timing for a talk at 9. But I've had a read through it, and essentially nothing I'm going to say is outdated. But I'll mention the new report as I go along as well. So, obviously, with all the data that they collect, there's a huge amount of stuff in the report. But I'm going to focus on the key ones that I've just spoken about in terms of key process measures. So, these are the kind of things that we get, which are normally fairly useful and tell us a bit about what we do as, well, England and Wales, as opposed to the whole of the UK. Pre-op risk assessment. So that shows a proportion of patients who are risk assessed starting 2014 over the left, going to 2018, and that's gradually increased. So we're now at about 75%. Today's report says we're at 77%, so we've gone up 2% in the last year, which is all good. Okay. The little blue lines are what we're targeting. Essentially, initial target was 80%, now it's 85%. Consultant presence, so this one shows consultant, surgeon and anaesthetist presence in theatres for those high-risk patients. And again, that's crept up quite nicely over the few years that the audit's been running. We're now at just around 80%, and it's the same figure in today's report as it was for that one. Critical care. Direct post-op admission to critical cares, as I said, one of the quality measures. And again, that's sort of crept up. So there's two lines on this one. The top one is critical care admission for patients with a risk of over 10%, which was pretty good to start with, to be honest. It's gone up a little bit. The bottom line shows the same number for patients with a risk of between 5 and 10%. So for our lower risk, high risk patients, we're getting better as a country. Results. Has it had any effect? And the answer is yes. Otherwise, it wouldn't still be going. But Important things to bear in mind or to think about. Length of stay. Since the start of the NELA audit, average length of stay for emergency laparotomy patients around the country has gone down from 19 days to 15 days, 15.6. Again, in today's publication, it's 16 days, so we're the same as last year, again. And that equates to essentially money, but also better outcomes for patients because they're not in hospital for as long. Mortality rate has gone down from about 12% down to about 9.5%. And headline figure from today's report, it's 9.6%. So essentially the same. So it is saving lives. Okay, so doing all these things that NELA suggests and improving these things that they suggest is saving lives. There are things that we don't do so well. So again, headlines from the previous report. 3/4 of patients with sepsis didn't receive antibiotics within the time frame, within the hour that they're supposed to. Over 1/4 of them didn't get to theatre in the time they were supposed to. So these are the most urgent ones, so NC pod, immediate, and emergency and immediate. Didn't get to theatre in the time that we assessed them that they should have. 3/4 or over 3/4 weren't assessed by geriatricians post-op, so these are the patients over 70. And bear in mind, the age limit's gone down to 65 now, so that's probably got worse. So, there's obviously good things. We've had some good results from complying with NELA data. There are things that can be done to improve, and we've known that for a long time. And there's lots of reports around the country, around the region, and in our own hospitals of how we've taken our NELA data, tried to improve something, improved it, and hopefully got better outcomes. There's some more publicised ones, like this one, which is quite commonly talked about, the Emergency Laparotomy Collaborative. So a paper published in the British Journal of Surgery in 2015, so around the beginnings of the NELA audit. 4 hospitals in the south of England got together and looked at the data and found that there are things that we're not doing so well. And they looked to improve those. The way they wanted to improve them was by implementing a care bundle, which looked kind of like that. So all NELA points, so risk scoring, antibiotics for sepsis, theatre within 6 hours for their patients, consultants in theatre, cardiac output monitoring, and direct admission to intensive care. Using their data, they implemented this bundle, compared 300 patients pre-bundle with 400 patients post-bundle. And I've stolen one of the slides from a presentation they gave a little while back, which shows what quite positive results from their side. So a significant reduction in risk-adjusted mortality in that short time just by introducing that bundle. Like I said, I've stolen that slide, partly laziness, but partly because it's got that little logo on the bottom, the Healthcare Foundation SHINE program. Essentially, what this has led to, because the results were so convincing, is that this has been scaled up to a national sort of initiative called the Emergency Laparotomy Collaborative on a national scale. So they are Emergency Laparotomy Collaborative throughout the region. So we've got one of these Midlands, West Midlands, Anglia, Yorkshire, London. Essentially groups of hospitals, representatives come together and have a chat about what's going well, what's not going well, share ideas, share data, and try to implement things that are going to improve care in a whole region as opposed to just in a single hospital. It's in its infancy, to be honest, but it has a potential for some improvements. So, I'm just going to move on a little bit from that and say that obviously NELA's been going for 6 years. The key performance indicators, which I mentioned at the beginning, were chosen 5 or 6 years ago. There's also potential for new indicators. Some things that have received a bit of interest recently, fluid optimization. We know that's important for all our patients, with pre, intra, or post-op. And currently the FLOELA trial is being run. Again, a lot of our hospitals here are contributing to that. Essentially, the question they want to answer is, does cardiac output monitoring for laparotomies during and for 6 hours post-laparotomy reduce perioperative or post-operative mortality? Data is being collected now, so results are going to be a couple of years at least. But there is some interest in that, and that might become a performance indicator or key process measure for later on. Other things, lung protective ventilation. So again, in its infancy, but a smallish study from London, observational study, almost 600 patients. Their conclusion from that was that intraoperative peak pressure and FiO2 were independently associated with post-op pulmonary complications. There's more work going on with that, and obviously that's something we could have all probably guessed. But until you've got the evidence for it, then you can start calling it a key process measure. So that's something for the future. Things are pending, things are changing. I couldn't give a talk entitled Best Practice in Emergency Laparotomy without talking about the best practice tariff, which has been enforced now around the UK since April. So essentially, if anyone wants to read it, it's dull. But hospitals now get more money for patients who have a certain pathway, a certain key parameters in their pathway of care. So the hospital has to have a process of care, a pathway of care in place, and the high-risk patients, so those scored above 5%, have to consult an anaesthetist and surgeon in theatre and go to critical care post-op. That equates to a bit of money per patient. And the hope is that that will drive increased compliance with these measures. And you'll notice that there are things I've spoken about already, so having risk assessment and consultants and intensive care, evidence-based measures. And the hope is that by incentivising that, you improve outcomes. Again, something for the future, which we may see. And there's obviously more of as it becomes more common. So, like I said, NELA 5th annual report is released. Again, it's a long document. There's a summary which is 3 pages, which is worth reading. Having a look this morning, conclusions essentially are that we've reached what looks like a plateau in terms of what we can do on a small scale within our hospitals and regions to achieve those parameters, key process measures that I was talking about. But there's obviously still a lot of work to be done on larger scales, systems reorganisations which might help to further improve those mortality and morbidity rates. NELA is ongoing. They extend it for 2 years, every couple of years. We might see improvements of the best practice tariff, we hopefully will. We might see new key performance measures, but in the meantime, like I said, local, regional projects continue, and I'd encourage you to get involved with those, because as I said at the beginning, 2,500 laparotomies that we're all going to come across in this region in the next year, so we can make a difference ourselves. Thank you. Any questions?